Uh, Welcome to our Critical Care Sunday webinars, dear students and colleagues and people from other disciplines other than intensive care. So today is webinar number 127, and today in our series of clinical pharmacology, we have respiratory drugs. Earlier we had taken neuropharmacology, and further on we'll take GI pharmacology, cardiovascular pharmacology, so on. So the speaker today is a very eminent personality in pulmonary and respiratory critical care, Dr. Manoj Goel, sir. Sir is Principal Director and Head of Respiratory, Sleep and Critical Care Medicine at Fortis Hospital, Gurgaon. So sir has many distinguishing features in his career. He's had more than 50 publications, including NEGM and Lancet. He is the author and editor-in-chief of Bronchoscopy in ICU. He is the member of various expert committee on Indian guidelines. He received the Young Scientist Award 2005 from NCCP, and he's also received the Chairman Award from ICCM in 2017, and also the Times Healthcare Achievers Legend Award in 2017 by the Jury of Times of India. He has Oration Awards from NAPCON 2020 and BronchoCon 2017, and has organized many conferences, and he continues to organize many conferences. So he has a very distinguished career and is a very nice speaker. I'm sure all of you will benefit greatly from this talk. So over to you, sir.
Thank you, Dr. Tapesh, for inviting me, and wish you all a happy Independence Day in advance. And very glad that you're sparing some time from your Sunday for this academic activity. And hats are off to Dr. Tapesh for continuing this CME series for so long. And as I heard, it's 127. So I'm really proud to be part of this CME. So I've just shared my slide. I hope they're visible now. Yeah. So my topic is clinical pharmacology of the respiratory drugs. And as a fundamental principle of medicine, we want to deliver the therapeutic dose of a drug at the target site, at the local site. The advantage is that we want to achieve optimal concentration of the drug at the local site and minimize the systemic toxicity. And fortunately, lungs give us that window of opportunity, unlike the other organs like the brain or the liver or heart. You have to resort to systemic therapy, but the local therapy can be, the mainstay of treatment in respiratory disorders. So if you have the opportunity of treating any respiratory disorder, whether it is a COPD exacerbation or any infective pathology, then you must try and achieve a drug concentration by nebulized route if possible. So that should be the target. Right. And next 20 or 30 minutes, I'll be elaborating on that. So why inhaled medications are required? Because the human lung comprises only a relatively low mass of the body, typically 1 kg in adult. So 60 or 70 kg of human being would have a lung which is weighing around 1 kg. So you can imagine the weight of the lung. And therefore, small doses of medication may be required to reach the lung for therapeutic benefit. But because if we have to administer through the systemic route, maybe oral or IV or otherwise, then we may have to administer large doses of the drug, which may cause systemic toxicity. Okay. So hence treating respiratory via oral or intravenous delivery may not be very efficient and may require systemic doses that cause side effects. In general, inhaled medications can be rapidly and non-invasively delivered to the respiratory tract and may have beneficial therapeutic effects there with doses that cause low exposure to the rest of the body to minimize systemic adverse effects, and we can achieve a good therapeutic concentration in the lungs. So the inhaled compound aims to maximize local exposure while minimizing systemic exposure, and that is the aim of a drug delivery. So what should be the attributes of inhaled compound? An inhaled drug should preferably have attributes providing retention of the drug in lung so as to optimize local exposure and to provide reasonable dosing regimen. Okay, so the drug should be able to retain itself, in the lung tissue, right, for a reasonable time, and therefore the dosing can be adjusted, reasonably. The drug should have high potency to limit the need for higher therapeutic doses. Okay? So you've got a drug which has a low potency, then require high therapeutic doses to be delivered through the inhalation route, which may not be practically possible. The other important aspect, the drug should have a low oral bioavailability to reduce systemic exposures. So when you're delivering drug through inhalation route, it passes through the oral route, and it has been seen that a large amount of it, or large percentage of the drug, is deposited in the oropharynx, which is then absorbed systematically and can cause systemic toxicity. So that's why it is recommended that after any inhalation, patient should rinse his mouth, so that whatever drug is deposited in can be washed out completely as far as possible. So we commonly do it for inhaled corticosteroid because there is a fear of dulling oral thrush. If the patient doesn't raise his mouth after the delivery of the inhaled corticosteroids. But for other drugs also, it is recommended that you should advise the patient to rinse his mouth after the inhalation therapy. A successful inhaled therapeutic requires not only the drug to be tolerable, safe, and effective, but also that it be compatible with a suitable delivery system. So the delivery system, the delivery device, and the drug formulation should be in sync with each other. They must be compatible with each other for optimal delivery of drug to the lungs. The solubility of inhaled drug in the airway lining fluid will also influence its behavior. With a soluble drug, all particles will dissolve in the airway lining fluid and are thus readily available to the receptor. So we must achieve, a drug formulation which should be soluble within the lung. However, with insoluble drug, there is a need to have a smaller particles so that the drug can dissolve the lining fluid. Okay, because large particles cannot be dissolved easily, so smaller particles may be needed to be dissolved in the lining fluid for drug delivery. And to ensure the delivery of these small particles in distant airways, right, then you may need the help of the binding of these molecules with the carrier particles in the formation, such as large lactose particles, right? So the smaller particles may not reach to the distal airways, where you may require the need of the carrier particles like lactose particles. So what happens in, when you got a meter dose inhaler, MDI, it has got a propellant. So propellant pushes the drug to the distal airways. But when the patient is breathing through the dry powder inhaler device, that is the DPI, then invariably these particles are small and they have a carrier lactose particle, right? So these patients, the patients who are using DPIs would have to inhale the DPI with a large force as quickly as possible. So that allows the drug particles to be reaching to the distal airways and also allows the dissociation of these particles from the lactose particles, that is the carrier particles. So for the MDI, what you recommend is that you would recommend the patient to breathe slowly at a inspiratory rate of 30 liters per minute. Whereas in DPI, you ask the patient to breathe in as fast as possible for the distal drug delivery, and also it's the dissolution from the larger lactose particles. Now coming to the inhaled anti-infectives. The rationale for administration of inhaled anti-infective is that the parenteral administration has numerous side effects. I have been elaborating a number of times. The aerosol administration produces higher drug levels than parenteral, which I'll show in the subsequent slides. The systemic antibiotic therapy may be ineffective even against susceptible organisms because of issues such as poor antibiotic penetration into the lungs. So like blood-brain barrier, you also have both the endothelial and epithelial barrier in the lungs, which may not allow the penetration of the antibiotics through these linings. Okay? Like tigecycline has a poor penetration to the lung because of this barrier. Now, this is a very important slide which shows the administration of tobramycin. So if you administer the tobramycin through IV route, then you can see the serum concentration achieved is 7.5 and the sputum concentration achieved is 82. Whereas that tobramycin is nebulized using an aerosol, then what you see the serum concentration achieved is 1.01, okay, which is much lesser than the serum concentration achieved through the IV route. But on the other hand, the sputum concentration achieved with the aerosol of the tobramycin is 1199, which is way higher than 82 achieved with IV. So you can see with the aerosolized tobramycin achieve higher lung therapeutic level and minimal systemic absorption. So it is going to be more effective with minimal systemic side effects of tobramycin. So this slide clearly shows how the aerosolized antibiotics or the inhaled antibiotics could be more beneficial, more effective while minimizing the systemic toxicity. So the advantages of inhaled antibiotics include high concentration of antibiotics in the pulmonary tissues. It also overcomes poor penetration of some of the antibiotics, for example, aminoglycosides, which are bound to proteins in sputum. So aminoglycoside has a poor penetration in the lungs. And there is also less systemic exposure and toxicity, which we have been talking about. The physicochemical properties of anti-infective, for example, lipophilicity, aqueous solubility, stability airway, surface lipid, affect the suitability of the drug for inhalation. So these things have to be taken into consideration while formulating these molecules, right, for the inhaled therapy. The important thing is the concentration of drug should exceed the minimum inhibitory concentration for the susceptible target organ. Otherwise, the drug is not going to affect. So MIC's level had to be achieved, as we have seen with aerosolized tobramycin. MIC achieved is much higher. Not only achieving high MIC is important, but also it's preferable that the anti-infective drug should exceed also the mutant prevention concentration, that is MPC. This is important to prevent the growth of less susceptible mutants to avoid development of antimicrobial resistance. So you must achieve a drug concentration which is above the MIC and also above the MPC. And this can easily be achieved with some of the antimicrobial therapies. But a key challenge with inhaled anti-infectives is that they typically have a low potency, and therefore you necessitate the administration of higher doses. And this becomes a challenge. The administration of higher doses of anti-infective through the inhalation route becomes a real challenge. Okay. The high dose of a drug and excipient delivered to the pulmonary epithelium also impose unique challenges from a drug delivery perspective. So what are these challenges? This limits the choice of delivery system to the nebulizer. So majority of the anti-infectives are delivered through the nebulizer. They cannot be delivered through portable devices like MDIs and DPIs. It also imposes constraints of formulation design, because you have to again look at those lipophilicity and lining penetration, bioavailability while formulating these nebulized drugs. There are also local safety and tolerability concerns. For example, there is post-inhalation cough, throat irritation, corpus cough, which is not uncommon with these patients with inhaled, anti-infectives. Especially of cholesterol, people do develop, reflux corpus spasm, coughing. So one has to be careful, especially, with the first dose of administration, where the chances are much more, and over a period of time, the tolerability develops, and then, these complications may become less. There are also concerns with respect to device portability, administration time, and daily treatment burden. So patient would require a nebulizer, and not only that, the administration time is very high. So for example, if tobramycin takes around 30 minutes for each nebulization, he has to take that nebulization twice a day, and that too for months together, especially if you're treating a patient with bronchiectasis. All right, so it may become a little cumbersome and may not be practically possible for all the patients. So this is the list of the anti-infectives. Tobramycin is FDA approved. It is an antibiotic used primarily in patients with bronchiectasis, cystic fibrosis. Fortunately, we don't have many cases of cystic fibrosis. Bronchiectasis is rampant in our country, right? And we commonly use tobramycin as a prophylaxis in patients with bronchiectasis, especially if they are Pseudomonas colonizers. So the patient with Pseudomonas colonizer with recurrent exacerbation of bronchiectasis, tobramycin becomes an automatic choice. Tobramycin and colistin both can be used, right, for prophylaxis in patients with bronchiectasis for preventing them from recurrent lower respiratory tract infection, especially if there is a Pseudomonas colonization. So it has to be used for months together. Okay, month on, you give a gap of about a month after use of 3 months, then again you go on. So this is how it goes on. Available as an aqueous solution that is given through a jet nebulizer. Similarly, colistin is available, again using cystic fibrosis bronchiectasis with the same indication. Again, a prolonged use is required and given through jet nebulizer. Amikacin is not available in India. It's primarily used for the treatment of NTM, that is atypical mycobacteriosis, where you require a high dose of amikacin for a long period of time, maybe a year or more, which can lead to systemic toxicity. So in those cases, amikacin is used as a liposomal dispersion formulation, and device that uses the e-flow, which is a special device, is not available in India. Zanamivir is a FDA-approved antiviral for the treatment of influenza. It is given as a disc inhaler. That's a dry powder inhaler. It's available as dry powder. It's given over 5 days only. So, but it's not available in here. Pentamidine is an antifungal which is used in patient 8, especially for the treatment of pneumocystis cervici, right? And is again given through a jet nebulizer. So various effective anti-infective drugs are available, and if we use them appropriately, then we have a possibly a game changer in the management of these cases. So coming to the Tobramycin, is the first inhaled antibiotic received marketing authorization. The Tobramycin inhaled contains 300 mg of tobramycin, 5 ml of sodium chloride. It has a pH of 6. The acidic pH enables the Toby solution to remain stable without the addition of preservative. So again, the pH and those pharmacological, the aspects are also very important for effective drug delivery. So all these things are taken into consideration while formulating the drugs for inhalation route. Compared with parenteral administration, pulmonary administration of tobramycin with a jet nebulizer, which generates a mass median aerodynamic diameter MMAD with short is of 4 mm, enables significantly higher dose of drug to be administered to the bronchial airways while minimizing plasma levels of drugs. The improved lung targeting afforded by tobramycin inhalation leads to reduction in Pseudomonas sputum density, improvement in lung function, reduction in pulmonary exacerbation, reduction in inflammatory markers, and also reduction in the incidence of systemic adverse events, for example, toxic, aflatoxin, which are so common with tobramycin when it is given through the IV route. In fact, Toby has contributed to a significant increase in life expectancy of patients with cystic fibrosis. And in our cases, of bronchiectasis, this has really proved to be a game changer. And it's also in patients of recurrent COPD exacerbation due to infections, the infective COPD exacerbation, we do advise tobramycin inhalation therapy for a prolonged period of time. Coming to the inhaled bronchodilators, the bronchodilators have been a mainstay treatment of symptoms from obstructive airway disease like bronchial asthma and COPD since ancient times. And there, various bronchodilators, Areca and others, which have been described in our Purans and ancient literature. So there are two classes of inhaled bronchodilators: Beta2 Agonists and Muscarinic Acetylcholine receptor antagonists. Okay, and we'll be talking about these briefly. So first about the Beta2 agonist. The Beta2 agonist cause bronchodilation by stimulating the airway smooth muscle Beta2 Adrenoceptor. So they stimulate the Beta2 Adrenoceptor in the smooth muscle of the bronchial tree and cause bronchial muscle relaxation and bronchodilation. And Beta2 agonists are classified into two subclasses based on their duration of action. The short-acting Beta2 agonists, commonly known as SABAs, these are the molecules with rapid onset, but have a short duration of action, typically only up to 4 hours. So they are used basically for symptomatic relief or for the relief of symptoms as reliever therapy or as a rescue therapy. Okay, so that is their main goal. Whereas a long-acting Beta2 agonist have a duration of therapeutic action of more than 12 hours. So that's why they're called LAMAs. Okay. So this is a list of the short-acting Beta2 agonists, that is SABA. Salbutamol, you all know that, available as Asthaline, right? Then you got levosalbutamol and terbutaline, and you can see they have a rapid onset action less than 5 minutes and short duration of action of less than 4 hours. So they're fast action, but short duration of action, right? So they have to be used only as a rescue therapy or reliever therapy. This is the list of the LABAs. The formoterol has a unique property that it has rapid onset of less than 5 minutes, similar to the levosalbutamol or salbutamol, but has a long duration of more than 12 hours. Now, formoterol is unique that it's also used for reliever therapy, like salbutamol. It's the only LABA which is used as reliever therapy also. It's recommended by GINA guidelines, the guidelines for the international guidelines for asthma management. Formoterol has a slow onset of action of 30 minutes and long duration of 12 hours. So basically, formoterol is used for maintenance therapy. The indacaterol and olodaterol, they are the newer introduction of LABAs. They have the advantage of rapid onset less than 5 minutes and long duration of more than 24 hours. So they're also called as ultra LABAs because of their long duration of action. But these indacaterol or olodaterol, although they got a rapid onset of action, are not used for reliever therapy. They're only used for maintenance therapy because of their very long duration of action. So formoterol is the only one which is used for relieving therapy as a LAMA. And it's a very important drug, as a matter of fact. It's now the first line drug, in fact, supposed to be better than salbutamol to be used for relief of symptomatic relief in patients with asthma in combination with inhaled corticosteroids. So that's something new, which is called as maintenance reliever therapy, where the formoterol and ICS combination is used not only for maintenance therapy, but also used for rescue therapy or reliever therapy. Right? So the patient has to use only a single inhaler. He doesn't have to use too many inhalers, just single inhaler, and then he can maintain or treat his asthma very well. So, as I said, the SABAs are used exclusively to treat acute episodes of breathlessness because of their short action, duration of action, and fast action, fast onset of action. The LABAs are used for maintenance therapy, taken regularly once or twice a day. LABAs are typically now only provided in combination with an inhaled glucocorticoid or anticholinergics and used mostly in fixed combination therapy. So LABAs are not available as monotherapy. Salbutamol is available as a monotherapy, but you will not find formoterol available as a monotherapy because it has been seen that use of monotherapy with LABA leads to increased risk of bronchial asthma exacerbation, increased mortality. So the LABAs as a monotherapy actually have been banned. So you will always find LABA in combination with either inhaled corticosteroid or in combination with the LAMA, that is long-acting muscarinic antagonist, which I'll be describing. Coming to the muscarinic acetylcholine receptor antagonists. So in human body, there are 5 muscarinic anticholinergic receptors, which are named as M1, M2, M3, M4, and M5. And as for therapy for obstructive pulmonary disease, M3 or M1 selectivity, and especially over M2 is the preferred option. So we have a large number of M3 receptors in the bronchial smooth muscles. They are the predominant muscarinic receptors in the bronchial smooth muscles. Now, these M3 acetylcholine receptors are localized to the smooth muscle in all airways. However, the density is much higher in large airways. This is what is important to understand. The M3 acetylcholine receptors are largest in density in large airways. So you want an anticholinergic effect or anti-muscarinic effect in the larger airways. So you want a drug which should be deposited in the larger airways. Right? So thus a formulation or device should predominantly target the large airways with the respirable particles of mean mass aerodynamic diameter SMAVD of less than 5 micrograms. Okay, these are the large size particles. Whether a muscarinic antagonist should be targeted to small airways too by a high proportion of fine particles, say less than 3 microgram or even extra fine particles, so less than 2 millimeter, is not clear at this point in time, mainly because the density of the M3 receptor is highest in the larger airways. Okay, so particle size less than 3 goes into the distal airways, the small airways, right? Whereas extra fine particles, in fact, go into the smaller airways, and it, in fact, up to the alveolar level, right? So we've got some, molecules available as extra fine particles. For example, beclomethasone is available as extra fine particle. The anti-muscarinic agents block the muscarinic effect of acetylcholine, such as bronchoconstriction and bronchial hypersecretion. So they are basically used for the relief of bronchoconstriction and bronchial hypersecretion, which is predominant in patients of COPD. So anti-muscarinic agents are in fact the first line treatment in COPD. So in asthma, the first line treatment is inhaled corticosteroids, whereas in COPD, the first line treatment is the bronchodilator, especially the long-acting anti-muscarinic antagonists. So the muscarinic acetylcholine receptors antagonists are also classified into subclasses depending on the duration of action. Short-acting anti-muscarinic agents called SAMA in short, very popularly known, and they have a duration of action which is shorter, but little longer than SABA. So again, they are to be used as a rescue therapy, like the SABA. Okay. The long-acting anti-muscarinic agents like LAMA, in short called LAMA, have a duration of action of 12 to 24 hours or long. So again, we got 2 classes of muscarinic antagonists, the SAMA and LAMA. So this is the list of the anti-muscarinic agents. So epratropium is a high potency. It's a fast onset of action within minutes. It's a short duration of action of 6 to 9 hours, and therefore it is called SAMA or short-acting muscarinic antagonist. Tiotropium has high potency, has a slow onset of action, has a renal clearance, and has got a duration of action of 24 hours, and is therefore called a long-acting muscarinic antagonist or LAMA. Glycopyrronium also has a duration of action of up to 12 hours, of 24 hours, but it has a rapid onset of action within minutes. So nowadays we are preferring glycopyrronium over tiotropium because of the rapid onset of action. Okay, So some of the pulmonologists are more interested in using glycopyrronium or prefer glycopyrronium over the tiotropium. And we know that tiotropium has been for years. Aclidinium is again a LAMA with a duration of action of 24 hours and has to be used twice daily doses, right? And the onset is, action is modestly slow. Umeclidinium has a duration of action of 24 hours and has a slow onset of action. The umeclidinium or glycopyrronium, they are the neurotraction and they're also called as ultra-LAMAs because their duration of action lasts 24 hours or more. Coming to the further explanation of this pharmacological profile and their use. So pratropium is a SAMA, right? Short-acting muscarinic antagonist used for the rapid relief of breathing difficulty, but not as a first line. The first line rescue therapy remains the SAMA, right? So if you want to use ipratropium, usually used as a combination with SAMA. Okay, so like levosalbutamol, ipratropium combinations available, which commonly we know as duolin. So I'm not marketing any company's product. It's just because they're commonly available and you are familiar with these, so I'm naming them. Okay. In chronic treatment, it is less effective than LAMA or LAMA. Therefore, in COPD, ipratropium is not recommended for a long-term use. Okay, right? Because they are less effective as compared to LAMA and LAMA, and they are the preferred choice. And they are, of course, use an additional bronchodilator in asthma, as I said, in addition to the short-acting beta agonist. Tiotropium is used primarily for the maintenance treatment of asthma. It is the first-line treatment in asthma, especially in the group A and group B patients. And they are also used as add-on treatment to ICS LAMA in asthma, that is step 4 and step 5. So if you want to add tiotropium, then your ICS LAMA dose has to be at least medium high. Okay, so low dose ICS LAMA, if the patient is doing well, there is no need to use tiotropium. You will use tiotropium only if the patient is, asthma is not controlled with medium to high dose of ICS LAMA combination, then tiotropium is added, otherwise it is not required. Glycopyrronium is again used as maintenance treatment of COPD, right? And can be used as add-on treatment to ICS LAMA in asthma. Aclidinium and umeclidinium are used as maintenance treatment COPD, and currently they are not recommended for asthma management. So a little bit about tiotropium is the most potent long-acting muscarinic antagonist, characterized by very slow dissociation from muscarinic acetylcholine receptors, qualifying for a once daily treatment regimen. It shows a kinetic receptor subtype selectivity, M3 over M1, especially over M2. So it's a highly potent, highly selective, right? And is long duration of action. Glycopyrronium has a duration of an action slightly shorter than tiotropium when administered once daily. So it can be also, given twice daily doses. The drug provides a rapid onset of action. That is the benefit of, glycopyrronium over the tiotropium. Aclidinium in COPD is administered twice daily dose, right? And efficacy and safety results are similar to other LAMAs. And same is the umeclidinium, qualifies a very long-acting LAMA by similar favorable outcome data and can be used once daily. Coming to adverse reactions of LAMA, the most frequent adverse reactions are dry mouth and taste disturbances, which is very common. Okay, and many patients do complain of a bitter taste after the LAMA inhalation. So again, rinsing the mouth helps them. The blurring of vision is another complaint. You have to be mindful of that, especially with nebulized therapy, because during nebulization, this drug, the eyes get exposed to the aerosol, and therefore these patients may complain of blurring of vision. So that is one thing. And urine rations, particularly the patient with the BPH, you have to be careful while using the LAMA because they can cause urinary retention, constipation, and of course can tachycardia. Coming to corticosteroids. The corticosteroids systemically used are classified according to their potency, mineralocorticoid effects, and duration of hypothalamic-pituitary-Adrenal axis suppression, that is HPA suppression. So based on these, the corticosteroids are classified. So coming to the potency first, the potency is expressed related to hydrocortisone. It is useful in determining the comparable doses. So hydrocortisone becomes the core drug, and we compare the potency of other corticosteroids with respect to hydrocortisone. Mineralocorticoid activity is also described related to hydrocortisone. Important thing is the steroid molecules are designed to increase potency as well as to minimize mineralocorticoid effects. So you want to minimize the side effects by reducing the mineralocorticoid effects like fluid retention and electrolyte imbalance. Duration of action. Based on the duration of HPA axis suppression, corticosteroids are classified as short-acting, medium-acting, or long-acting. One thing is important to remember, that duration of action is not well correlated with the duration effect, possibly due to the intracellular mechanism. Because the mechanism of corticosteroids intracellular, the effects persist even after corticosteroids have disappeared from the circulation. So please understand that duration of action is not same as duration effect, right? The duration of action may be short, but the effect of the corticosteroids may last longer because of the intracellular mechanisms. The onset of effects of systemic corticosteroids often delayed for 3 to 8 hours, regardless of the route of administration. Again, this is because of the intracellular and nuclear effects of these therapies. So that's why, there is no added benefit of giving IV hydrocortisone over oral corticosteroids like prednisolone. So in fact, all the guidelines talk about the prednisolone, right, during the exacerbation of asthma and COPD. They don't talk of the hydrocortisone, okay, because the onset of action is going to be the same, and dose-wise, they become equipotent, all right. So there is no extra benefit of administering hydrocortisone 3 times a day over prednisolone 20 milligram 3 times a day patient who is weighing, say, 60 kg. So this is a list of systemic corticosteroids. So hydrocortisone is short-acting, prednisolone, methylprednisolone, and deflazacort is intermediate-acting, dexamethasone is long-acting. The anti-inflammatory potency related to hydrocortisone. So if we level the anti-inflammatory potency of 1, the prednisolone is 4 times more potent than hydrocortisone, methylprednisolone is 5 times more potent than hydrocortisone, deflazacort 3.3 times, and dexamethasone is 25. So what you do in practice, that you want to achieve equipotent dose. So for potency of 1, you deliver a dose of 20 milligram hydrocortisone. You administer a dose of hydrocortisone 20 milligram. And this would be equipotent to the 5 milligram prednisolone, 4 milligram of methylprednisolone, 6 milligram of deflazacort, and 0.75 milligram of dexamethasone. So you're actually not looking at the potency. You're actually looking at the dose which is equipotent. Okay. So if you want to achieve the same potency, you will achieve the same potency with 20 milligram of hydrocortisone with 5 milligram prednisolone. Okay. The duration effects depends upon the HPA axis suppression, and the hydrocortisone has a duration of 8 to 12 hours. Prednisolone, methylprednisolone, they have 18 to 36 hours, and dexamethasone has 36 hours. Okay, more than 36 hours. Similarly, the mineralocorticoid activity is least with dexamethasone. So if somebody has got a congestive heart fluid retention, you would try to use dexamethasone compared to others. So hypothalamic-pituitary axis suppression is an important consideration while administering the corticosteroid, because the risk is associated with the daily dose of corticosteroid, the number of daily doses, time of day of dosing, duration of therapy, specific agent use based on short, medium, and long duration of action. We'll try to understand this in a little bit of detail. So it has been seen that higher daily dose of corticosteroids are associated with a higher risk of HPA axis suppression compared with lower daily dose. So if you're using 40 milligram prednisolone for 1 month, then the HPA axis would be more if you're using a dose of 20 milligram daily for 1 month. So high dose has a direct bearing to the HPA suppression. Now, when the same daily dose is used, multiple doses have a higher risk of hypothalamic-pituitary-adrenal axis suppression. For example, 10 milligram 3 times a day of prednisolone has a greater risk than 15 milligram twice a day, which has a greater risk than 30 milligram daily. So you would prefer using a same dose, okay, but in a single dose, right? So that should be the idea. Daily doses that are administered at times other than early morning have a higher risk of HPA axis suppression. So for example, 20 milligram prednisolone at noon or 3 p.m. has a higher risk of 8 a.m. So you would like to use the minimum possible dose as a single dose, and that too in the morning, to prevent HPA suppression. Longer duration of therapy presents a higher risk of hypothalamic-pituitary axis adrenal axis suppression compared with shorter. So if you use prednisolone for 6 months, the HPA suppression is likely to be more while using for 2 months, right? So that is one has to understand. Therefore, the tapering has to be adjusted accordingly. Agents with a longer duration of action have a higher risk compared with medium or short duration of action therapy. For example, dexamethasone therefore would have a higher risk of causing HPA axis suppression as compared to others. Now, compared to take care of the HPA suppression, we have to taper the doses of corticosteroid, particularly if they are used for a long period of time. So general recommendations regarding the need to consider tapering regimen are if you use prednisolone 30 mg daily or equivalent for at least 2 weeks. So if you used prednisolone in this dose for 2 weeks or any other drug with equivalent doses for body, then you have to think of tapering it. Any dose of any systemic corticosteroid for at least 1 month. So if you use any dose, say 15 mg or 20 mg 1 month, then you have to taper it rather than stopping it abruptly. Or if the patient has signs and symptoms of hypothalamic-pituitary-Adrenal axis suppression, existing with him, then of course you may have to taper it very carefully. And sometimes in these patients, you may have to continue with the maintenance dose of the systemic corticosteroids, right? If the patient has got permanent or prolonged HPA axis suppression. One thing is that it is generally unnecessary taper doses in patients who receive corticosteroids for 5 to 10 days, which is among the most common regimens used for acute treatment. So if you used, steroid for 5 to 10 days, there is no need to taper it off. You can just stop it, right? So, and this is what we generally do. A patient with COPD exacerbation or asthma exacerbation, or in patient with sepsis, where we used as a corticosteroid for, septic, the hemodynamic instability, then you may not have to taper it off. Unfortunately, the use of tapering in these situations can lead to longer exposure to the corticosteroid than necessary. In fact, this can be more detrimental and counterproductive because then the steroid is used for a longer period of time. Tapering of corticosteroids when appropriate is an art rather than a science and may require frequent adjustment to the tapering schedule depending on how the patient is tolerating therapy. So there is no golden rule. It is just a clinical judgment, right? And your clinical acumen which decide how to do tapering in patients who have received corticosteroid for a long period of time. For example, shorter use of corticosteroids can be tapered fast, whereas longer duration of treatment require slower tapering. A general observation is that the duration of taper should be 33 to 100% of the treatment course. Coming to inhaled corticosteroids, just a couple of last few slides. In 1972, the first inhaled glucocorticoid, that is beclomethasone, was introduced as MDI. This is the list of inhaled corticosteroids. Beclomethasone, budesonide, they are available as DPI, MDI. Then fluticasone propionate, furoate, mometasone. Most of the time we are using budesonide and fluticasone propionate. That is the most commonly used, inhaled glucocorticoid. And again, they are equipotent dose by dose. So they can be used as low, medium, high dose. So a dose of budesonide 200 and 400 milligram is equipotent to a dose of 100 to 250 milligram of fluticasone propionate, right? So again, the dose is equipotent. A little bit of the pharmacology of the inhaled corticosteroids is too complex, but I'll spend a few minutes on that. The pharmacological effects of ICS are mediated through glucocorticoid receptors. So these receptors are there in the smooth muscles of the airways. The magnitude of the receptor binding affinity of ICS is designated relative receptor affinity, RRA, with reference to a receptor affinity of dexamethasone of 100. So dexamethasone has been given a receptor binding affinity of 100, and the other molecules are compared with that. So this is the list, and as you can see, this is the dexamethasone, which is used as a reference, has a receptor relative receptor affinity of 100. And you can see mometasone has the highest the receptor relative receptor affinity of 2200, followed by fluticasone propionate, and the budesonide has 935. Okay, so the highest is fluticasone propionate and mometasone furoate. Important thing to remember is that high receptor binding affinity alone does not necessarily translate to an increased therapeutic ratio or enhanced clinical effectiveness, right? So it doesn't mean that mometasone would be more potent. And at the same time, one has to remember that higher is the receptor binding affinity, more is the systemic absorption, therefore more of the chance, there would be systemic toxicity. Okay, so this is important to understand, and this receptor binding affinity is actually one of the aspects of the potency of the inhaled glucocorticoid. There are many other factors, right? For example, the formulation and particle size, the lipophilicity, the bioavailability, the metabolism. So there are many factors, the prodrug, there are many factors which actually are taken into consideration, right? Which decide the potency of the drug. So just by saying that, mometasone has the highest relative receptor affinity is the most potent is not going to be right way to understand. Okay. Right. So a little bit of formulation particle size. A particle size of less than 5 millimeter is more likely to be deposited in bronchi and bronchioles compared to particles of more than 5 millimeter, which are often deposited in the mouth and throat. So you want to keep a particle size of at least 5 millimeter. Larger particles, which are more likely to be deposited in the oropharynx cavity, can cause local side effects such as oral candidiasis in horses, and therefore it is mandatory that after any inhaled therapy, mouth rinsing with plain water is highly recommended. Among the ICS in comparison, fluticasone propionate delivered by DPI has the largest mass median aerodynamic diameter of more than 6 millimeter, followed by budesonide, which is 2.5. So you're likely to expect highest deposition, oral deposition with fluticasone propionate. Cyclosinide and budesonide delivered MDI have the smallest particles, and they can reach up to the smaller. So if you are looking at the ultrafine delivery, ultrafine particles, then budesonide is the drug which has the ultrafine particles. Sorry, it is a beclomethasone dipropionate, not budesonide. Beclomethasone dipropionate. Okay, which in fact is a prodrug, and it is converted into a beclomethasone monopropionate, right? Which is the molecule used for the therapeutics. Now coming to the various devices, who is the winner, and there is a lot of discussion. Whether the meter dose inhaler is better or nebulized better or DPA, that is the tripod inhaler, is better. The jury is that ultimately it is the teamwork which is the winner, right? So choice of device will depend upon the availability of the product. For example, in fact, anti-infectives are not available, as majority of them are not available as MDIs or DPIs. So there's no choice but to use them with nebulizers. And often a question is asked, which is better, the nebulizer is better or what? My simple answer to that is what suits the patient the best. That is the main thing, right? For example, a 70-year-old lady who is practically bedbound, you don't expect her to use MDA or DPI for inhalation therapy. That patient, you would think that the nebulizer would be a better choice, right? So, but a student who is 12-year-old, right? If you expect him to nebulize himself for 3 or 4 times, that is not practically going to be possible. In those cases, the MDA or DPI would be better. All the devices, have a good drug delivery, provided the technique of inhalation is appropriate. Then they have got almost equal drug delivery. Various devices are available which are trying to meet the need of the patients, right? So I think deciding about the delivery device has to be discussed with the patient, his preferences. And many times when these patients come, they've already been on some kind of delivery device, and you ask them which device they feel is the best, is the one that gives them the best, relief. So ultimately, I think it's a teamwork, what the disease is, what medication you use, and how much patients compliant, and how much you involve the family members in the caregiving of these patients. That is going to decide and would prove to be the ultimate winner. Thank you very much. I tried to keep this topic as practical as possible and as clinically useful as possible, rather than going too much into the nitty cases of pharmacology and pharmacokinetics. I hope I have done justice to the topic, and if there is any question, I'll be very happy to, respond. Thank you very much.
Thank you very much, sir, for a very nice presentation. So, audience, if you have any questions, please put them up. So, sir, just a few comments I would like from you. First of all, you mentioned the use of anti-infective therapy for, in terms of cystic fibrosis and bronchiectasis, which are the accepted guidelines for nebulized antibiotics. European guidelines do not recommend antibiotics for HAP or VAP or community-acquired pneumonia. Nonetheless, people are using it, and there are several trials which have shown efficacy. So what is your comment, sir, on the use of colistin or amikacin or tobramycin for pneumonia, especially HAP and VAP in the ICU?
So if, a patient who has got, tracheobronchitis, possibly, these would be the first choice. honestly speaking. And I have to see what kind of organism is a gram-negative multi-drug resistance. I can use them as add-on therapy. See, as far as the multi-resistance treatment, the treatment of multi-resistance concerned, it's still a very gray area, and most of it is based on the expert device and the personal experience. I don't see any disadvantage of using, the inhaled antibiotics in these situations. Particularly, the studies have categorically shown that the lung deposition, the lung concentration achieved with the inhaled antibiotics is much higher as compared to systemic antibiotics. So somebody has got a renal toxicity, the AKI, and you want to use tobramycin or you want to use colistin. I think inhalation in combination with systemic antibiotics would be the choice. So you don't use inhaled antibiotic as a therapy in pneumonia. You use them as add-on therapy. But when you talk of bronchiectasis and cystic fibrosis, or in infective COPD exacerbations, right? You can use them for the prevention of infective COPD exacerbation. You can use them for long-term therapy.
Right. So other point I would like you to comment on, sir, is the use of inhaled nitric oxide or prostacyclin in cases of acute cor pulmonale with, having pulmonary hypertension, or pulmonary hypertension in cases of chronic cor pulmonale leading to decompensation of right ventricle and leading to right ventricular failure. Any comments, sir? Use of inhaled nitric oxide and prostacyclin?
Yes, they are approved, and they are in fact advisable. And in fact, for the the pulmonary artery reactivity, reversibility, the inhaled nitric oxide is actually recommended, where you can find, this will decide whether, the calcium channel blockers or nifedipine would be useful in this. So idiopathic pulmonary arterial hypertension, you do a nitric oxide challenge. And if there is a, this challenge is positive, then, this patient is going to be benefited by nifedipine and is likely to have a better prognosis. So they are recommended, but unfortunately, they're not widely available. So I don't have a per se in-hand experience of using these drugs. That's why I did not include my talk. But if they are available and you've got a patient like this, then they are recommended and they should be used, especially severe pulmonary arterial hypertension, right? They are recommended and they should be used.
Right. So then coming to the last point, steroids. You see, there are different formulations and different formulations are advised in different conditions. COVID, we have dexamethasone. In steroids, in ARDS, we have methylprednisolone. So is there, where does the difference lie? Is it just on the basis of trials that we are using different kinds of steroids, or is there something more to it?
So actually, when you want to use the systemic steroid, then you've got limited options. Okay, IV, especially if you want to use IV, then you got methylprednisolone, right, or dexamethasone. These are the two available. And dexamethasone you don't want to use because this has long half-life and longer onset of action. So methylprednisolone becomes our automatic choice, and that is why in ARDS patients the maximum trials are with the methylprednisolone IV, right? And these patients are many times in sepsis, so you're not sure about the oral bioavailability of drugs or GI bioavailability of drugs, so you would use IV. So I think the trials have used these drugs based on these aspects, and I would go by the drug which has been used maximally in those trials rather than saying that they are equipotent. So no, in ARDS I would like to use prednisolone rather than methylprednisolone. I think we should follow what has been done in the trials, and then accordingly we can choose that. In that cases, I think we should not be so determined or fixed that no, we can use any of them.
Yes, I think I agree. Whatever the trials have shown, we should go by them for whatever reason. So I think there are no questions from the audience, sir. Thank you so much for enlightening us. It'll be up on our YouTube channel along with the previous 125 videos for all of those who may not know. Thank you, sir. Thank you very much.
Thank you very much, and very obliged to be on this channel. Thank you so much.
Pleasure, sir.
Looking forward. Thank you. Thank you.